how about we start with some introductions, if you don't mind introducing yourself.
Okay, fine, Jess. So I'm Dr. Tina Peers, and I trained as a GP originally, and I worked for 7 years part-time as a GP, and then I became a consultant in contraception and reproductive health, and did that for 24 years. And I also became a menopause specialist, which is now where my main body of work is. And you might well be thinking, what on earth is she doing talking about long COVID and mast cells? But I developed a big interest for this condition in 2015 when I diagnosed my youngest daughter with it, who had been extremely ill. And then I couldn't help myself. I kept diagnosing 4 or 5 people a week who I was seeing for contraception and other things. And my interest has developed since then. People have sort of, found me. And now I'm very interested in treating long COVID patients. And I have treated about 40, I think, to date. So that's me, really.
Okay, so on my part, I'm an engineer by education, a filmmaker by profession. And for those who don't know my story, I was in the middle of, well, not the middle, I was almost at the end of my marathon training for the London Marathon last year, when I started to feel a bit nauseous. And that was my first symptom, which was March the 13th, so almost 11 months ago. And that was the beginning of a journey that has completely changed my life in all sorts of mad ways. I haven't run properly more or less since then. There was a foolish month in probably the second month of my journey where I thought I can exercise out of this, and even just gently, it was too much. I look back now and I wish I hadn't tried to. But I'm still, my energy levels are better now than they were, and I think this is probably typical of a lot of long haulers. It is slightly better now than it was, but I'm running at probably about 50% power now, rather than sort of the 20% power like things were when they were really bad. And my current symptoms are fatigue. I've had to go and lie down 3 times today with like waves of fatigue that just sort of strike and render you completely useless. Headaches, although the last week or 2 hasn't been too bad. And then sort of inflammatory skin issues, which I'm still dealing with, and sort of stomach acidity and all sorts of other mad stuff. So that's me in the long COVID context anyway. So before we take some questions, Tina, I was actually just going to ask you a couple. And the first one was, how frequently do you see MCAS in your practice?
Right, quite frequently. This is going to surprise some of the doctors out there, possibly, who aren't so familiar with it. We call it we actually say that it's frequently seen and seldom diagnosed, because it actually is really quite a common condition. And we know that 10 to 20% of the population have allergies of one sort or another. And in a sort of minor sort of way, that is MCAS, that comes from the mast cells. But generally, we also think that between 10 and 17% of the population, and this isn't an exact science because it's a very new, young science, but we estimate between 10 and 17% have got a more dysfunctional mast cells than just a little bit of an allergic reaction occasionally. So I see it really quite frequently. The numbers I see would absolutely concur with that. So I would say probably, yes, 17, 18% of my patients who come for the contraception or for menopause, they have a previous history to display, just sort of make me think, oh gosh, you've got chronic inflammation going on here. So it's very different in different people. So in some people it's very bad, and in some people it's more minor. In some people it's there all the time, and in some people they have exacerbations occasionally when something triggers it.
So, I mean, I'm going to ask you a question I asked Dr. Afrin as well, which is, how does it present, and what kind of conditions do people turn up being aware they've got, but maybe haven't realised that actually MCAS is driving it?
It can be so many different, it can have so many different presentations. And I think that is what is confusing for the medical profession who aren't very familiar with it. So patients could present with IBS, for example, so that's inflammation of the gut. So they could have constipation or diarrhea, bloating, wind, etc. Then it could present with headaches, where their predominant feature is vasodilatation caused by histamine, and that gives them headaches. It can present with fatigue, especially post-virally, when it seems to have a big effect and cause a massive fatigue. So it can also present with rashes and various skin conditions, so rosacea, psoriasis, eczema, or just dermatographism. Dermatographism we know is caused by high histamine, and that's a very clear sign that somebody's got some mast cell issues going on. Some people just present with abnormal swellings. They get something called angioneurotic edema, or they wake up with swollen faces and swollen lips, and no one can quite work out what the trigger was sometimes. Sometimes people talk about, they have palpitations and low blood pressure, and they can have POTS type syndromes, which I believe is coming from MCAS. So their blood pressure drops because of the vasodilatation, and then their heartbeat goes really fast to try and sort of get oxygen to their brain, and they feel very faint. So these sort of drop attacks, and et cetera, et cetera. So it can be so many different presentations, and sometimes it presents not just in one way in one person. They may have several different systems that are being affected, and sometimes people just have one. They just have a history of severe IBS, and usually these patients have been really investigated. They've been to see a neurologist who's checked out their funny pain in their neck and in their jaw with no obvious sort of pathology in their teeth and jaw and so on, but they've got this very definite pain there. That's very common. They'll have, or maybe a neurologist for their headaches. They might have seen a gastroenterologist for their gut, and they're told they have dysbiosis. They have, sort of things going on in their gut which aren't very good, and leaky gut. They might see a dermatologist for their skin, etc., etc. They might see a respiratory doctor for their chest because they can get shortness of breath, and it's not quite asthma, but so it doesn't respond to asthma treatments, but it's a similar kind of feeling as asthma, and so on. And they will have had loads of investigations. And by far the majority of those investigations will have come back absolutely normal. And then everyone sort of slightly draws a blank. And the poor patients are left still with their condition, but with no answers and no treatment.
It really is an enigma, isn't it? And I think, Dr. Afrin sort of spoke about it quite well in the film, where he was saying just how difficult it is to actually test in terms of biomarkers for it, because of how few places can actually do the tests required, and just how sensitive those tests are, that any, the blood sample needs to be warm for a couple of minutes and you've had it. The science is so immature here in terms of being able to identify it, and then also knowing how to treat it. It makes it incredibly difficult.
Yes, he described that very well, actually, didn't he? Talking about there are actually only about 10 unique biomarkers for histamine intolerance and mast cell activation, and they go so quickly. So heparin, for example, is gone in 30 to 60 seconds. Once you've taken the blood, you've lost it basically, and so it's very, very common for everything just to come back normal. And our laboratories just don't have the right equipment, the sensitive enough equipment. They don't have the sensitivities to detect the small changes that occur, and they may look like a very small change when they're being calibrated, but actually they can have a huge effect on the body, because these chemicals are so potent, and that's one of the reasons why they've been designed to disappear quickly too, because you don't want something that's so potent hanging around in the body for too long. And if the immune system was working properly, you want it to be there when you need it and then gone. But unfortunately, the MCAS type patients, and I think with the long COVID patients, they're there, and then they're still there, and they're still there, and it's still having its effect. And it doesn't just go away.
And hence chronic illness for months and months. Right, let's see if we can field some questions. I'm going to press some buttons and see what happens.
Okay.
Hi guys, I was wondering if it matters whether you take the non-flush version of niacin or just the regular, and what quantities would you recommend taking? Thanks.
Well, Jez, you're the expert on the flushing niacin.
Dr. Bensel's feelings were that in his experience, the non-flush had side effects, but for some people, the flushing side effects they get, I don't know what the proportion is of people, but some people can't really tolerate the flushing variety. So if you're one of those people, then I think you're best off sticking to the non-flush. But if you can tolerate the niacin, then great. And dose-wise, start small, start after a meal, just to be sure. And when I say small, probably like 20 milligrams, something like that. If you start, because you can just buy 500 milligrams from my local chemist, for example.
That's too much. Too much.
And that, some people would really struggle with that. Quite an unpleasant reaction.
It can be, and I've experienced it myself, and it was horrendous. It was absolutely awful, and it's strange because the first time I took it after a meal, I didn't have any reaction at all. I thought this is fine, and the next day I took it after a meal and drink plenty of water. It says to do that. I did all of that, and then about 20 minutes later, I was standing at my computer, and my face went so hot and so red, and not only that, it was covered in like allergic bumps all over my face. It just was horrendous, and it lasted an hour and a half, and it was so uncomfortable and such an extreme reaction. But I've been taking niacin no flush for years, absolutely fine, 500 milligrams to 1,000 milligrams a day with no issues whatsoever, no side effects at all. So I usually recommend the no flush, but I know that Dr. Bensel prefers the flush. But anyway, I think people should try, but as you say, low dose.
Yes, start low. Indeed. Okay, we've got some questions again. I think we are actually finding the original people have found their way back here by some magic or other. I have a question.
I don't know if my question got deleted, so I thought I'd ask it again. My GP is, they know something's going on. She suggested long COVID last week. I've had like a 3-week sick bug, and I've had anaphylaxis recently, which I think sparked her interest, and I get the head of the GP now calling me. How can I bring up MCAS to her for her to look into it, because that would be really helpful if she would actually look into MCAS, but I'm not sure how to ask her to look into that, so she could up my dose of antihistamine medication. Thanks.
Tara, that's a really good question. There is, on the Royal College of GP's website, there is a toolkit for EDS, for patients with hypermobility, EDS. And in that recommendation and that toolkit, there is a section on MCAS. And I think it's quite helpful to have, you could print that off, or you could get the link and send it to your GP. That's quite a good place for them to start looking at MCAS and start understanding about the condition, because as I said, it hasn't been on many doctors' radar really, for all sorts of reasons. I think Dr. Afrin covered that very well in his interview with Jez, that we're given as doctors a minute or one lecture on mast cells in the whole of our medical training. And so it's and then that's it, and you're told you'll never see a case of mastocytosis because it's so rare. And they unfortunately didn't realize that mast cell activation syndrome we will see all the time, and it's very common. So one sort of doesn't sort of keep up with that. But anyway, I think I would refer your GP to this toolkit on the RCGP website. I would also get the link to Dr. Afrin's and Dr. Moldering's article that they wrote, and it was published on the 10th of September in the International Journal of Infectious Diseases, and it talks about the inflammation, hyperinflammation, COVID-19 and mast cells, and you could present them with that too. There are some few papers coming out now looking at long COVID and the treatment of long COVID. So, and in some of those papers, it does link to mast cells. So you might want to do a little bit of research yourself and then pass on this information to your GP to help them, because they're incredibly snowed under at the moment and very busy. So anything that if you make it easier for them, all the better.
Yes, indeed. Right. Next question.
If the antihistamine diet doesn't work, should I try antihistamines as medicines?
I think he's asking thereabouts over the counter versus prescription. Am I right in understanding that?
Yes. I think you might be. Yeah, I think you're right. So I would start with the over-the-counter ones, but make sure you take them in a reasonable dose. So that's cetirizine or loratadine, something like that you can buy over the counter. It's a 10 milligram tablet. It'll say on it once a day, but I would try it twice a day. If you're on other medication, please just check with your GP before you do anything like this. But if you're not on any medication at all, then certainly I would take an over-the-counter antihistamine, and I would take it twice a day, so 12-hourly, and I would try it for a couple of weeks. And if it helps you feel better, then stick on that one. If it doesn't, then try a different one. And when you've come to the end of the ones you can buy over the counter, then I would ask your GP to prescribe for you, because it's not always the case that the prescription ones are better than the over-the-counter ones. It's very much an individual thing, and then so you have to find out for yourself a little bit first. You can't get any type 2 antihistamines over the counter, unfortunately, and there's only 2 available in this country, and one is completely out of stock. So the only one we've got currently is for motadine, and you really want to take 20 milligrams twice a day of that, and that's prescription only. So you'd have to ask your GP for that. By the end of the month, we're hoping nizatidine will be back, and that's 150 milligrams twice a day. And then, one would try one and see which of those is better as well. But you must add one thing at a time. So once you establish which type 1 antihistamine helps you the best, then you add in the type 2, and then you can work out whether it's making you feel better or worse or not really doing anything.
Yeah, it's a pity that, again, we're still at the stage of trial and error with all of this, and I think Dr. Afrin was saying how he'd love to see a future where you can test someone's genetics, and you can do sort of a blood test and a urine test, and you can work out exactly which drugs will work without having to go through this whole process. I don't know how far away that future is, unfortunately.
Yes, sadly we're not there yet by a long shot.
No.
But,
yeah. All right. We've got the questions are piling up. Let's go again.
When you say struggle, what is the side effect that you said some people can't handle?
Oh, I don't know if that was that. Sorry, I didn't catch the start of that question.
I think it might be about the flushing. Do you think that's a question from before, Jez?
I do. I think it's probably about the niacin, and the answer is no. I don't actually have. Dr. Vensel didn't mention what the side effects were that were unpleasant with the non-flushing, and I'm not. It's not. I mean, maybe I think this question comes up so much. I might actually just pop him an email and actually just get some clarification on this, because is it as good? Does it work as well? And if so, what are these side effects? Because I get asked it the whole time. So that's probably one to follow up on.
Yeah. I've been recommending the no flush niacin to all of my menopausal ladies for years, and none of them have come back and told me that there are any side effects. So I'm slightly surprised by that. So it'd be interesting to hear what he has to say. Yeah,
indeed. Right, let's go again.
Hello. I just want to start by saying thank you to Jez for all the great journalism. I think your reach is farther than you might realize on your YouTube channel, and it has been very appreciated over the last few months. My question for Dr. Piers is, how does one explain the fact that if mast cells have a 12-week life cycle, those of us who have never had mast cells problems in our lives before, no allergic reactions of any kind, no inflammation, no issues, are experiencing so many months of problems with MCAS? And would you say that that's probably related to viral persistence? In other words, is the virus still in our bodies somewhere? Is it still affecting mast cells? Is it infecting them in such a way that they are sort of broken even when they are reproduced or recreated? Or is it the mechanism that creates them that's at fault? I wonder if you could speak to that. Thank you.
That's
very good question.
An excellent question. Yes, excellent question. We have a very strong suspicion that there's viral persistence, and we are looking into that at the moment, aren't we, Jez?
We are indeed.
Yes, Jez and I have been. We were asked to help with a pilot study for some research that's going on at Bonn University in Germany, and so we actually a couple of weeks ago I took blood from 21 long COVID patients. Jez organised everything brilliantly, and it was all picked up by courier and rushed over to Germany. And they are, as we speak, looking at the serum of these patients to see if there's evidence of the spike proteins still being there, therefore the virus still being there. And I suspect they will probably find that it is, and that's what's constantly stimulating these mast cells. Now, very interesting you say that you've not had any issues previous to COVID. I've seen 40 patients so far who are long COVID sufferers, and out of 40, I would say there's one patient who hasn't got a history which suggests their mast cells were a little bit dodgy pre-COVID. So everyone else has got some thing. They may have considered themselves to be very healthy people and be running and be quite athletic and so on, but there'll be something in their history usually that's sort of eczema that keeps cropping up, or headaches, or all sorts of little bits and pieces. Oh yes, I can't, if I have too much coffee, I get diarrhea, or if I do this, something else happens, which suggests their mast cells are a little bit sort of aggravated quite easily and are reacting to things that they should be ignoring. But as I say, there's one patient who hasn't got any history like that at all. So I'm not saying that all of the long COVID explanation is to do with mast cells. Goodness knows, I think it's part of the picture. It's probably much more complex than we realize, and we may not know the full answer for quite some time. But so a lot of the patients do have a history suggestive. Yeah.
I would agree with that, and I fit into that quite nicely in the sense that I had latent MCAS that didn't bother me on a daily basis or a monthly basis or a yearly basis. I had occasional eczema that would crop up once or twice in my life at times of stress, and I'd get a bit of hay fever, for a week or two when the particular pollens were out that triggered me, and that was it. But I suspect I fit into the 18% of people who have some form of MCAS, and the reason why I think we're seeing the proportion of sort of 10% of people who get long COVID symptoms, they are probably a proportion of that 18% whose mast cells are triggered. And I would say if you had a Venn diagram of that 18% and the 10% you had long COVID, I think you'd find a large degree of overlap. That would be my punt in the dark if I was going to make one on that front.
I agree with you.
And in terms of viral persistence, at the moment, it would explain a lot if we can find it. And I think both Tina and I are very excited to see the results because if it's there, at least we know what we're dealing with, right? If it's not, then God knows what's going on.
Well, interestingly, today I was reading a piece of research that was written in Argentina, and it was a case study of a doctor who had long COVID, and he had severe hip pains and shoulder pains when he had the coronavirus, and then he was fine. He seemed to make a full recovery, and then 6 months later he got a debilitating pain in his hips again, exactly like he had when he was ill. And they actually gave him ivermectin, and they give it for up to 20 days to people who have long COVID. And he made a complete recovery from this. And their theory was that it's because there's viral persistence, and the ivermectin actually got rid of the virus that was lurking in his joints.
Lurking in the joints. I mean, that's the thing, right? If it is lurking, I mean, you can imagine that it might be lurking in the small intestine, as that study found in a few people. And actually, it could be that the reason why we're seeing long COVID is that maybe it is sitting in the small bowel, for example, of lots of people who've had COVID, but the only people who it's actually producing symptoms in at that stage are the people who have latent MCAS. And do you see what I mean? It could be something like that. Anyway, look, we've got more questions piling up, so I'll stop. I'll stop blabbing on.
If my current H1 blocker is giving me a rash, do I need to switch to a different H1 blocker, or do I need to come down on my dose? Thank you.
I would switch to a different one. I would switch to a different
Yeah.
one. You've obviously got a hypersensitivity to that particular one, and even a small dose would probably do that to you. So, you know, there are several different types, so I would swap, definitely.
Which are the main ones on prescription that you would consider prescribing?
The main one is fexofenadine, that is really nice and strong, and that one, the doctors, GPs often just want to give it as a 180 milligrams maximum once a day, but actually we give it up to 4 times a day, and that is the maximum safe dose for a few days if somebody had an exacerbation. So often people end up feeling better if they take 180 milligrams, say 3 times a day or twice a day. They usually settle with twice a day, actually, but some people find it's better to take it 8 hourly. So we've got that, and then we've got things like promethazine and chlorpheniramine, etc. These are the ones that would require a prescription as well. Yeah, and then we're very limited on the type 2s, unfortunately, as I explained before. We used to have ranitidine, which was lovely, and then the FDA pulled it because they said it contained some excipients that increase the risk of cancer, but it's the basis that they're sort of putting that on is very weak, because millions and millions of people have taken it for many decades without any increase of cancer risks and so on. And so, yeah. But anyway, they've taken ranitidine away, sadly.
Yeah. And also for motadine, you won't necessarily find it in stock either. At a lot of chemists, they'll have to order it in. It's mad that there can be a sort of a category of drug that's so hard to get hold of.
I know, it's crazy. And at the moment, we can only get famotidine 40 milligrams. And so I have to ask my patients to cut it in half to take 20 twice daily. But you can't write that on the prescription because the pharmacist isn't allowed to dispense it if you put that kind of instruction. But, you know, really you want 20 milligrams twice a day, ideally, not 40 milligrams all in one go.
Yeah. Right, let's go again.
Can histamine food be brought back into a low histamine diet after a few months if it's tolerated, or does it need to be a complete 6 months histamine-free diet to replenish the cells?
That's a very good question, Craig. I think if you tolerate it, it's a sign that you can do it. So I would go low and slow and take a tiny little bit and see if you're okay with it. And then maybe leave it 3 or 4 days before you try it again. And I've certainly got some patients who aren't long COVID patients, but who are MCAS patients. And they have, one lady recently told me that, you know, she's been able to reintroduce a bit of garlic and some onions into her diet. And actually, one of my long haulers has also said that, and they seem to be getting away with it, and that makes their diet a little bit more interesting, thank goodness. So I think I would try. You'll know if you feel unwell after it. The reaction can be almost immediate, or it can be up to 36 hours later. So you just have to try things gently.
I mean, onions and garlic, I would have thought, were fairly low. They're not the real killers, are they?
No, I mean, garlic is low. Onion seems to be quite high in some people, whether there's another chemical in it that they're actually reacting to. In Sainsbury's, they have these white onions which have a white skin on them, and they seem to be the lowest histamine. So if you can get hold of them, they're not always there. Now we won't be able to get hold of them at all, will we?
Yeah, I was going to say good tip, but yeah, if you can find them. Right, let's go again.
Is it common with MCAS that if you go overexert yourself at night, if you get an inflammatory attack, like any time after like midnight or in the early hours, sort of once you're fully asleep, is that something that's common with MCAS? Because I always thought that was perhaps an autoimmune disorder or something unique to COVID that I had. Is that something that you find happens with people with MCAS?
Yes, it does. It does. So it seems that any kind of cardiac exercise will release histamine into your system, and then it will cause havoc potentially. And it may well be that it's, you know, because of the time frame of it, that it's when you're in bed that you're going to be aware of that. So that's something that we've definitely come across, not just in the long COVID patients, but certainly in MCAS patients. And generally, people with MCAS tolerate weight, sort of doing weights and yoga and Pilates and that kind of exercise, rather than jogging or going on the treadmill kind of exercise. So I would caution people when they're starting to get back to some kind of activity, not to go for a run, not to make that the first thing they go to, but to actually do weights and things. So you can get into pretty good shape, well, very good shape, doing weights. And so at least you'll feel that you're not losing all your muscle tone, etc., without giving yourself a cardiac workout.
Yeah, I have put on 10 kilos since last March, and not in the right places, unfortunately. I've now started reintegrating press-ups because I am seeming to tolerate them. There was a time when I tried to do like 20 press-ups back about 6 months ago, and within literally 30 seconds, the headache suddenly kicked in. And I was like, oh my God, I can't believe it's that direct. But I can actually do 20 press-ups now without getting the headache. So I'm trying to turn some of those.
That's a really good sign, Jez. That's a really good, you're going in the right direction. You really are.
Slowly, but hopefully in the right direction.
Too slowly for everyone's satisfaction. But anyway, never mind.
Hello, Jonathan here. I'm primarily dealing with a lot of chest pain throughout all of this, and of course got it checked out through the cardiologist, and everything came back fine. And he's saying he's seeing 2 or 3 a day with similar circumstances, previously healthy, no issues, and now suffering with quite a bit of chest pain. What is the role of MCAS, particularly with that symptom, and is that treatment plan of, you know, the H1 and H2 blockers and the vitamin stack that was previously mentioned? Is this really just a waiting game and kind of following that treatment course? It seems to be very little answers surrounding these particular symptoms, and quite a bit of pain on a daily basis in areas that typically you're told to be concerned about, your heart and other such issues. Just interested in your feedback on the role of MCAS in chest pain particularly.
So this is something that seems to be quite a feature, actually. You're not alone at all. And as you say, your respiratory doctor said he was seeing 2 or 3 cases a day. I think it is MCAS, and I think that you need to, there can be some fibrosis which can cause pain and pneumonitis. And I think that, you know, we'll know more when we know about the viral persistence for a start. And secondly, I think you do need the full whack of all the MCAS treatments. So I would go for type 1 and type 2 antihistamines. I would try those. I would definitely have a mast cell stabilizer, such as montelukast, which you could take 10 milligrams twice a day. You can have, if you're in America, you can have nebulized sodium chromoglycate, which is amazing, or chromalin, and that seems to work very effectively for patients with these kind of symptoms. Unfortunately, we can't get that here in the UK, but I think in America, in the States, I know you can. So I would be trying that, and a lot of these things are going to be trial and error, I'm afraid. The other thing that you could do is some hydrophysiotherapy, so breathing exercises in water. That seems to help the lungs. And montelukast isn't a mast cell stabilizer, it's a leukotriene antagonist, so it's a slightly different mechanism of action there. So you could have a mast cell stabilizer and the montelukast. So I think I would go through the same kind of categories of different drugs to try and trial and error, add one thing at a time, and see how much progress you can make.
That's one thing I've been lucky not to have, is the chest pain and the breathlessness, but it does seem to be incredibly common amongst long COVID. Thank you for that question. I hope it's helped.
What do we know about viral persistence?
In a nutshell, what we know is very little. We've currently got what we've kind of got to go off is the autopsies of people who've died with COVID, and that's very different to long COVID, but they have found the virus everywhere, all over the body in those autopsies. Now, obviously, with people who are alive, you don't necessarily get to take those biopsies, but there was one study that was done a couple of months ago that was looking into it was actually looking into the length of time that antibodies were around for, and how they sort of waned over time. And they did gut biopsies on a very small proportion of people in that sample. And on 50, when I say a small proportion of people, I think it was 14, perhaps, if I made that up, but it was around that kind of number.
It was 14. Yes, it was 14.
Yeah. And I think of those, 7 of them, they found evidence of what looked to be active virus in the small intestine, and these were people between 3 and 6 months after infection who didn't have symptoms otherwise. So this is that's kind of all we've got to go off right now, aside from the pilot study that we're involved in, which hopefully we'll get to hear back on soon, because we are directly looking for viral persistence there. Now, what we can't do is say where in the body it is when we get those results. We'll just know if there is some, because it's just picking up the spike protein in the blood. But so to answer that question, that's kind of all we know about viral persistence, which is there's a lot of sort of fingers that point at it, but we haven't really found anything conclusive yet to say that's what it is. And am I right in saying that, Tina?
Yes, absolutely. No, spot on.
Yeah.
So watch this space, really.
Yeah.
I've seen some sources list lectin as a trigger with MCAS. Would you recommend reducing lectin-containing foods in your diet?
I think there are different people with this condition are sensitive to different things, and it's very much a question of you trying to work out what you particularly are sensitive to and what are your triggers. And there's no quick fix for that, I'm afraid. So yes, some people could be sensitive to that, as could some people to salicylate containing food, etc. So you have to try and be methodical in your approach and sort of fairly scientific in your approach, and keep notes of what you do, and don't scattergun it, otherwise you'll get yourself really confused. So, you know, low histamine diet, fine, and then have a look at what the lectin containing foods are and reduce those for a bit and see if that has a positive impact on your symptoms. And if it doesn't, put them back in, otherwise you'll be hardly eating anything. So, you know, I'm afraid it's a bit of trial and error, and it's going to vary from one person to another.
Yeah, indeed.
Can I take HRT while trying the low histamine diet?
Yes, you absolutely can. And I have that a lot of the time. That's when I'm diagnosing this, is my ladies who come for HRT. Now, with HRT, women who have MCAS generally are progestogen sensitive. And so sometimes it's quite difficult to find a progestogen component for the HRT that they can get on with and tolerate. So that's the first thing to say. So that's a bit of a clue when people come and see me and say, oh, you know, I could never take the combined pill or the mini pill, it just made me feel awful. Then I think, oh gosh, are they progesterone sensitive? And then the other thing that happens is during the perimenopause, when estrogen levels are just fluctuating wildly, you know, even within the space of a day, that will have an effect, a negative effect on histamine levels, because histamine and estrogen reinforce each other. So if the estrogen goes high, then the histamine is going to be pushed up. And so the last thing you want to do is, you know, so then when patients come with that, they have quite a confusing picture sometimes. A lot of their symptoms are from histamine, and they could also be menopause symptoms. So one has to be very careful and try and lower the histamine in the histamine bucket as before one then embarks on HRT. And then with the HRT, we go very, very gently, because we're aware of this sort of reinforcement that can occur. And, you know, and I have a lot of patients who have MCAS who are happily settled on their HRT, but it just takes a little bit longer to sort of sort it all out and get them settled. So yes, absolutely, have a low histamine diet if you think you've got histamine issues, whether you're on HRT or not, but be aware that you're estrogen, don't be too ready and eager to increase your estrogen doses too rapidly, and be aware that you could make your histamine worse.
I think you're probably one of the best people in the country to have answered that question, Tina. I don't know who else would have been better qualified to comment on that particular combination.
That's good.
MCAS, or high histamine, I think it causes tinnitus. Now, I've been following the diet for some time now. I've been taking antihistamines, and the one thing I can't control is the tinnitus. What would be your advice to try and reduce the noise from that? I've been following information from the, Tinnitus UK, but if there's anything from an MCAS perspective that would be a good focus, that would be great if you could mention that. Thank you.
Yes, tinnitus is an absolute horror, and it seems to be a very common feature in the long haulers and in MCAS patients. And I think, again, it's just a question of going through the different treatment regimens as much as you can with a clinician who is willing to hold your hand and be patient and take you through them. You could try also the use of low dose naltrexone. That is something, LDN it's called, very low dose. That has been found to be helpful. And I think tinnitus is such a difficult symptom because it's so in your head, isn't it? And you can't get away from it. Even when you go to bed, you can't get away from it. That it's worth trying absolutely everything to try and sort it out. But it is literally a question of working a way through the different treatment regimens. And if you care to look at Dr. Lawrence Afrin's paper that I mentioned earlier, that was published in the International Journal of Infectious Diseases in September, he does very clearly identify the different treatments to try, actually. And that's written for acute COVID, but it sort of applies to the principles are the same.
Right, let's go again.
What was the results of the study done on viral persistence, and are we still going down that route?
We've answered that. We haven't got the results yet. Is the answer to that question. Hopefully soon.
Do you believe that the long COVID sufferers have actual MCAS, which I believe you will have for the rest of your life, or if it's just kind of we have the same symptoms?
Do you know, we don't know. We don't know. So as I said earlier, a lot of the patients I've seen, which is about 40 so far, they have got a history suggestive of MCAS in their previous pre-COVID lives, which, they were most of them were tolerating it fine, and it didn't stop them living a very fulfilled and happy life. And so I would imagine once we get this particular episode under control, that they will go on forward in the same, very much the same vein as they were sort of pre-COVID. So, but I suspect there are probably some people who haven't got MCAS at all, but it's just absolutely irritated and overstimulated their mast cells. And once we calm it all down and get rid of any virus, if there is viral persistence, that they would then get back to normal. I think one of the things we need to learn from this whole thing is that we all need to convalesce more when we've had illnesses. And we're very, very bad at doing that. When we get a virus of any sort, whether it's the Epstein-Barr virus, which is glandular fever, or Lyme disease, or chickenpox, or swine flu, or COVID, once we start to feel better, we really rush back to our normal daily routines and exercise and rushing here, there, and everywhere. And I don't think that's very good for our immune system, because our immune system has just been hyperstimulated by whatever infection we've had, and then it needs a time to just calm down, and therefore we should take a few days to convalesce, to just take things easy, meditate, to be calm, do a few things that you really like and enjoy doing, spoil yourself, and then ramp up slowly back to normal life. And I think if we did that, we wouldn't see so many people with chronic fatigue, etc., etc. And I suspect a lot of the long haulers did exactly that. They rushed back to work because they felt guilty that they'd been off for a wee while and needed to get back into the normal routine. And I know it's difficult if you've got small children, you've got to put money, bread on the table. It's very difficult, but I do think we need to keep that in mind going forwards.
Yes, agreed.
How important is it to have an actual diagnosis? For example, here in Scotland, I'm not aware of any specialists in the area. Am I better just going ahead and trying to identify something that works for me, or should I press on and try and get some sort of medical advice around it?
It's a very good question. I would press on and try and work out what works for you, because there's nothing to stop you doing that. As I say, if you're on any medication or you have any other comorbidities, other illnesses, please talk to your GP before you start trying different things out. But in the main, I would absolutely get on with trying to get over-the-counter type 1 antihistamines, lower the histamines in your diet. And some patients find that taking a non-steroidal anti-inflammatory is really helpful. So ibuprofen, 400 milligrams 3 times a day after food, that sort of thing. So you could try some of these things, which are sort of self-help, if you like. The problem is that so few doctors know or have heard about it. I think, hopefully we're trying to change that, and this will hopefully help a little. But so few doctors, it's not on their radar. They've not heard about it. They don't know anything about it. And whilst they want to help, they may not be feel knowledgeable enough or confident enough to start prescribing you things. So I think at the moment I would press on, and also go and ask your doctor. Don't give up on that, but to make a start. And I've had quite a large number of people get back to me and say that even just changing their diet and taking type 1 antihistamines has changed things dramatically for them. So it's worth a go.
Yes, very good advice.
So I have a question about the nervous system and a possible link with MCAS. Do you think the theory that MCAS is rooted in a nervous dysregulation of the limbic system? Do you think programs such as the Gupta Program or the dynamic neural retraining system can help with MCAS?
I absolutely think it can, and I know it is helping. So definitely the Gupta Program would be something that I recommend to all my long COVID patients. And some of them have taken it up and found it extremely helpful. So I would encourage you all to have a look at that. It's guptaprogram.com, and the program is spelt as an American spelling. Very, very good results. He on his website, you can see Dr. Gupta does this for patients with fibromyalgia, which I believe is based in mast cells, for chronic fatigue syndrome, which I believe is mostly based in the mast cells, for MCAS itself, and for long COVID. And even if it helps you to improve by 10% or 20% or 30%, it's helpful. But yeah, it's all about retraining of the amygdala and the brain. Yeah.
Hi, Dr. Piers. Just on your website, it mentions celiac disease as a possible trigger for MCAS, and I was wondering if you could maybe expand on that. I've had celiac disease for 50 years and currently suffering from long COVID. Thanks.
So we're not quite sure how they're all linked together, but we do think that MCAS is very much at the center of quite a few autoimmune type diseases, and celiac is actually genetic, isn't it? We've got a gene that can show whether you are celiac or not, and we haven't yet drilled down to work out what the absolute link is genetically with MCAS, but I certainly see a lot of it. So I have a lot of my patients who have MCAS also are very sensitive to wheat. Some of them, I believe, though, are diagnosed as celiac when they're actually not. It's probably because they've got MCAS and they've got histamine intolerance, and wheat is very high in histamine. So it's not a very clear picture, I'm afraid. That's not the best answer, but that's all we can do at the moment.
Yeah, it's a pity how much of this science at the moment is this vague. We can see some of the links, but we don't yet quite have the understanding to work out the mechanisms necessarily,
Hi guys, just wanted to say thank you so much for the amount of work you're doing. It's really an inspiration. My question is, basically I had chicken pox when I was 18, so this was like 6 years ago, and after that I developed the symptoms like rashes, headaches, which was MCAS, but it wasn't as severe as how I have it now when I had COVID. So my question is it possible that chicken pox, I don't know, a sickness such as chicken pox can induce MCAS, so to speak? Because I was just curious, as in I never got the actual diagnosis for it because they just thought it was allergies. So yeah, that's my question pretty much. Thank you.
So Tom, it's a very good question. I think that a lot of the patients I see have got probably slightly hypersensitive mast cells. And then when they get a nasty infection like chickenpox, and certainly if you're 18 when you got it, it generally is much more severe than for children. So it could be Lyme disease, it could be chickenpox, it could be swine flu, it could be just a really nasty bout of flu. Patients, when they get that, if they've got slightly oversensitive mast cells, then that can be a big trigger for the mast cells becoming very, very irritated and releasing these, there's over 1,000 different mediators that they release. And some of those mediators then play havoc, which would have given you a lot of your symptoms. We don't even know which ones would have given you which symptoms, to be honest, but we do see this as a pattern that people after a viral infection can be, affected by rashes and headaches and IBS and etc. So yeah, I think that that probably to me would just probably explain that you have got a slight propensity for your mast cells to be a little bit oversensitive, and then something like a severe virus will trigger them off. And then you've had another one now with the coronavirus, sadly. So you're seeing the same kind of pattern. Yeah, very common.
Tina, I think originally this was planned to go to 8, but seeing as we got booted off for a bit, are you okay to run a few minutes longer and try and get through a few more of these questions?
Yes, let's do a couple more. That'd be fine.
Yeah, great.
If NAD deficiency is the driving force behind MCAS imbalances in long COVID, how do you balance the recommendation between the two when they are contradictory? Like avocados, peanuts, fermented food like sauerkraut, and drink kombucha, which can boost your NAD plus levels but are also high in histamine. That feels like a conundrum. Thank you.
Oh, my take on that is that you take nicotinic acid directly as niacin to deal with NAD plus deficiency if you are suffering with MCAS-like symptoms. If you're NAD plus deficient and you aren't suffering from MCAS-type symptoms, you might be able to get away with those other foods. I don't know if you would agree with that sort of sentiment, Tina.
I do. I think, yes, you can take it in a supplement and avoid the high histamine foods, because that you're going to be on hiding to nothing if you're going to be eating things that are such high histamine, like avocados, just to get the niacin. So you're going to be benefiting one thing and making something else worse. So I agree with Jez. I think it would be sensible to be low histamine at the moment, add the niacin as an extra in a supplement. And then as you get better, hopefully you can start reintroducing some of those other foods again.
Yeah, indeed.
For people that have developed a lactose intolerance, is that a sign of MCAS, or is that a sign of damage to the gut that maybe the virus has done?
Actually, lactose intolerance is a genetic condition. So you've either got it or you haven't. The pure lactose intolerance. Having said that, so a lot of patients with MCAS are lactose intolerant, even though they don't have the gene and they can digest lactose, because lactose is often lactose containing foods are very high in histamine, and therefore they cause a histamine mast cell response in their gut, which results in nausea or vomiting or diarrhea or whatever. So you've got two things going on. It's a very complex picture It may be that they're not lactose intolerant at all. It's just the lactose containing foods are high histamine, and it's the high histamine that's upsetting their gut, and not the lactose. So I hope that answers your question.
There was one other question actually, which I said I would ask on their behalf, and that was, what role does the gut biome play in MCAS?
Well, we don't know, but probably a very, very important one. So we know that the microbiome is critical with our immune systems, and our immune system is all about mast cells. So, I mean, there are other cells as well, but predominantly our mast cells are very key players in that. So I think we're going to learn more and more over the next few years. And I think we're starting to make inroads into this kind of research, which particular bacteria are helpful in the gut with patients with MCAS. And certainly you want to have a nice, healthy microbiome that supports the gut lining, for example. You don't want bacteria in there that that cause the lining to break down and increase the leaky gut syndrome, or cause SIBO, which can then cause a whole load of problems. So it's really, really important. And some of my patients, we're doing their gastric analysis, their stool samples are being sent off, and looking at the different bacteria that are there. And it can be incredibly helpful to know that, because then you can start taking some probiotics that have the right mixture in them. And certainly all of my MCAS patients, I recommend a probiotic, usually a good multivitamin mineral tablet, the various supplements, extra supplements that we've talked about, a good probiotic. And often, if you have semi-digested food in your stools, a digestive enzyme with each meal can help considerably. So yeah, I would have a look at the microbiome. I would have some stool samples sent off and analysed, and work with a good nutritional therapist who should have experience and be able to advise you on that.
Excellent.
I have another question. Could MCAS have an effect on the adrenals, or the other way around? I have a very low level of DHEA, which apparently corresponds to a 90-year-old woman, and I'm 37. And since I've been supplementing in DHEA, I've felt much better in the fatigue area. So I was wondering if there could be a link between that and MCAS. Thank you.
Yes. So although patients who have immune deficiency don't necessarily have MCAS, there certainly can be quite a link between the two. So it's usually because of dysautonomia caused by the MCAS that you can get the fatigue, etc. And yeah, I mean, it's interesting the DHEA has helped you. That's excellent. I'm afraid I'm not going to give a very concise answer to this, because we just don't know. We don't know how everything interacts with each other currently, because there are over 1,000 different chemicals that are released by the mast cell, and we don't even know what all of those do and the effects that they have. But if something works for you, then absolutely brilliant.
Which histamine blockers would you recommend, specifically for the H2, I believe it is? I have fexofenadine, which I believe to be H1. Currently looking for a H2. Is there any that you'd recommend taking alongside fexofenadine, which may work better? Thank you.
So Tom, there's only 2 that you can get hold of at the moment in the UK, and one is for motadine, which you would need to do 20 milligrams twice a day, but at the moment we can only get 40 milligram tablets. So if you chose to cut those in half, that would be fine. And the other one is nizatidine, which is out of stock currently, but should be back in stock hopefully end of February, early March, and that's 150 milligrams twice a day. So those are the 2 that we've got at the moment, and I would try one and then try the other. Famotidine is much more expensive than nizatidine if you're getting private prescriptions. Nizatidine is definitely the cheaper option, but it's not available currently.
Sorry, another question from me. Following on from the exercise question, I'm a gym manager, does that mean I'm never going to be able to go back to work? Or, because I've been off for 5 months now, how would you sort of say the best way is to manage that, or go about obviously returning to work and easing myself back into any exercise?
Des, you're the expert on exercise.
Well, yeah, well, I guess it depends, I guess, what your role as a gym manager involves. If by that you mean you're doing a lot of personal training work, I think I would try and keep as Tina said earlier, try and keep the cardio elements of those to a minimum. And if it's a question of doing weights or reps rather than cardio work, you may find that places less of a burden on you. At the end of the day, I think the best advice is just to go very gently and see what you can tolerate, and don't jump back in at the deep end, or jump back in at the level you think you used to be able to work at. So without knowing exactly what your role involves, that's probably the best advice I could give.
Yeah, I would agree with that. And you're going to have to take it gently. And, as more and more information comes out, don't assume that you're not going to get back to your previous health. I would say that to everybody. I would hope all of you are going to get back to your previous health, and that's going to be our goal. And as more information becomes available and more drugs come online, then we're going to be hopefully able to move more and more towards that.
Yeah, in terms of just being able to recover, actually, that's quite an important note. I mean, the same question came up about 5 times when I posted the link to this film online on YouTube, which is, if MCAS is a chronic condition and now I've got it with long COVID, does that mean that I'm going to be like this forever? And I think my understanding is that, well, the way I've been looking at it is that you probably didn't realize that you had some form of latent MCAS previously. That's now been exaggerated and exacerbated hugely, but there's no reason, as long as we can get rid of the viral persistence, if it is viral persistence, and if it's not viral persistence, then we ought to be able to, our bodies ought to be able to settle over time anyway, and you ought to be able to get back to the old you. I don't think that doesn't mean that you've necessarily been escalated to the top level of MCAS suffering, which maybe some people had beforehand, if that makes sense, Tina.
I agree with you, Jez. That was very well put. I think it's just possibly revealed it in many people, and then hopefully, as we calm things down, I would hope and envisage everyone will get back to how they were before, and some will be even better than they were before because they'll have worked out what some of their funny symptoms and conditions were. So yeah, I think I'm hopeful that we will calm things down.
Yes, I for one am going to eat fewer tomatoes in the future, whether I'm better or not.
Yes. Yes,
Hello,
I think
Dr.
I
Piers.
think
Thank you for answering questions tonight.
Oh, God, I just looked. Sorry about that, Tina. What were you saying?
No. It's okay. I think our modern diets are geared towards revealing and exposing MCAS actually, and because we do so many things that we didn't used to. So when I was little, you had tomatoes in tomato season, and you didn't have them all year round, and you certainly didn't have them every day, and you didn't have avocados and spinach every day, and you didn't have strong fresh coffee. You didn't have as many types of tea or green tea available, and people didn't drink or seem to drink as much alcohol. So and we didn't have TV dinners, and you didn't really get leftovers. So all of those things, unfortunately, and processed foods are so high in histamine that I get the feeling that has revealed a lot of the MCAS symptoms and that people get because of their lifestyles, really. And we're stressed, stress increases it too. And one of the biggest symptoms that people express is anxiety. And I just really want to say something quickly about anxiety, because I want to reassure people. I've got several people who've just become so anxious, and they were really cool, calm and collected before, and felt very in control, and suddenly they feel completely at a loss to explain why they feel so anxious. And the problem is that when your histamine is high, your body tries to bring it down, and it does that by releasing adrenaline, and adrenaline makes you feel anxious. So you're sitting there minding your own business, and suddenly you're hit by this bus of anxiety that you cannot explain or cope with or control, and it's not your fault. It just isn't. It's not that you're thinking wrong or that you're doing anything wrong. This is your body trying to get the histamine down, and it will pass. It really will pass. And we also think that histamine in the brain, when it causes inflammation of the brain, can cause all sorts of symptoms, such as the fatigue and the cognitive dysfunction, that brain fog that everyone talks about, depression, and panic attacks if the anxiety is so bad, and also some psychoses that we believe it can manifest itself in a psychosis, and actually it's the inflammation of the brain from the high histamine.
Yes, I'd also just like to say sorry to Jen, whose message I interrupted, and I may not be able to get it back now. So if I've lost your question, Jen, I'm really sorry. I think we've got time for...
Sorry.
No, it's all right. I think we've probably got time for one more, and then we'll wrap it up.
Yeah. Okay.
So here we go.
Where does resveratrol come in the equation of your treatment plans? Is it the case that it's something you add or have added to the stack? Or is it something that would be left for later? Because there's a lot of stuff about autophagy and fasting, and we're wondering about going towards the 3-day resveratrol idea. Can you comment on that?
And actually, just before you answer that, Tina, one of the things that's been coming at me a lot recently on YouTube is this idea of fasting, and it really seeming to help some people. So I don't know if you can address that and include it in the question.
It's very interesting that the fasting does seem to give the body a rest. And so many patients have noticed that if they fast, basically they're not taking any triggers, then everything can just be calmer and very much better. Now, I am not familiar with the use of resveratrol, I'll be absolutely honest with you. And I would be very interested to see any data on its use in this way. I think that it's a natural polyphenolic compound, isn't it? And it's in red grapes and things. So I think it's got an anti-inflammatory effect. So potentially, yes, we could be looking at using it, but I haven't seen any data on it. So I'm sorry, I can't give you a fuller explanation.
And I guess, okay, so before we wrap it up, is there maybe one piece of what is the most, maybe with one question, which is, what is the most common single piece of advice that you have found, or your patients who are suffering with long COVID have found helpful over the last few months?
Oh goodness, one piece. I think lowering the histamine in their diet helps, because they have, no matter what you do drug-wise, or supplement-wise, if you're putting too much histamine into your system when it's already overloaded, you're just not going to start feeling any better. And unfortunately, hard as it is, and I do appreciate it's very difficult, if you can lower the histamine that you're taking and stop the tea and the coffee, which block the diamine oxidase enzyme that's reducing your histamine, then you can start to see some progress. Now, I've got one patient who I've come across with long COVID who it didn't make any difference whether they had histamine or not. So there's obviously it is a complex picture and something else is going on with them. But that's one out of many hundred who have reported that it's helped. So I think that's probably the first thing to do, and to be patient.
And I guess just for people who maybe joined us a little bit later, one other final question would be for people who are struggling with their doctors to help them, make them aware of MCAS, or to help them maybe get their doctors to prescribe them the antihistamines they need. Could you just remind people listening where they can direct their GPs to get those resources that might help them?
Yeah, so I think it would be useful for them to look at the Royal College of GPs website for the toolkit for EDS. There's a toolkit on there as a document, and it's got an MCAS section, and that's a very good initial introduction for GPs to start their fact finding. The second thing I would do is I would refer them to Dr. Lawrence Afrin's, Moldering's, and Reinhardt's article in the International Journal of Infectious Diseases that was published in September. I think that's also very good. There's some very good mast cell websites, actually. There's Mast Cell Action. Let me see if I can remember, give you the full Mast Cell Action.org, I think it is. That's also very good. And there, and I think there's also a very, very important website that people should look at, and that's the FLCCC Alliance website, which is another session we have to do, Jez.
Yes, indeed.
On ivermectin.
Yes.
But have a look at that website, because that is full of interesting studies and data, and talking about treatment of long COVID as well. As it's on there too.
Great. Well, Tina, thank you so much indeed for your time this evening. I hope that we have helped some people navigate this rather confusing landscape together.
Yes, thank you. It was a pleasure. Very nice to talk to you and with everyone.
Yes, and indeed, and I'll be obviously in touch on social media. I'll be putting the link to this on Twitter, so you can catch up with this or share it with anybody else. And there'll be, I think, future sessions diving into whatever else develops in this space, whether it's viral persistence or indeed ivermectin, which I think is another big onion with many layers to be attempted to be taken off.
Absolutely, absolutely, brilliant. That's great.
Great, cool. Thank you, Tina. Bye-bye.
Good night.
Good night.